Thank you very much, Tyler. I'm absolutely thrilled to be with all of you today. I am getting a little bit of feedback, so if anybody out there is not muted, it would be appreciated if you would do that. As I'm sure you know, healthcare is entering an era of massive change. Major transformation began over the last few years, and the pace of change is definitely picking up. There are signs of this change everywhere you look. The quality and safety movements are real and they're accelerating. The need to control the costs of care are substantial and unavoidable. Exciting new possibilities for delivering better care are becoming apparent. These changes will be powerful and profound, and they will be far-reaching. Everyone involved in healthcare will feel the impact of these dynamic events over the next few years. However, in order to really understand how we got to this point, it is important to understand where we've been. How did we get to our present state? That will be the focus of today's presentation. Over the past decade, much has been written about the problems with healthcare in the United States. While the need to improve quality and decrease costs is certainly very real, it is also important to not forget what is good about our healthcare system. The purpose of this presentation is to provide an overview of the historical, cultural, financial, and social forces that have defined and shaped the existing healthcare system and the dynamics that are irreversibly driving the need for change. This will set the stage for later presentations that will review the emerging concepts and methods that will allow clinicians and healthcare organizations to adapt to a rapidly changing future. As I mentioned in my initial overview presentation a couple of months ago, I am in the process of writing a book on healthcare transformation. The book will be freely available to anyone who is interested in reading it. The goal of the book is to provide an overview of the current and future state of healthcare transformation and to provide clinicians and healthcare organizations the knowledge they need to be successful over the turbulent decade ahead. As indicated on this slide, the book will have 3 sections. Section 1 will focus on the forces driving transformation, both the influences that have defined our current system and the present and future challenges facing the industry. Section 2 will focus on the concepts and tools clinicians and healthcare organizations need to understand and implement in order to successfully ride the wave of transformation. Section 3 will look into the future. It will describe what success will look like for clinicians and healthcare organizations that successfully utilize the tools and concepts presented in Section 2 of my book. The future of analytics and other important healthcare technologies will also be discussed in Section 3. Initially, the plan was to have the book completed and available this month. In fact, the writing for the book is largely complete. However, the process of editing and graphics production is taking a little longer than we anticipated. At this point, we are anticipating that the full production version of the book will be complete and available in late April or May. However, the full production version of Section 1 is complete, and as Tyler said, it is available to anyone listening to today's presentation. Before we start, I'd like to pose a couple of poll questions in an effort to better understand the audience. Please take a moment to respond to these 2 questions. First question is, how are you involved in healthcare? Are you part of an integrated delivery system, a hospital, a physician group? Are you a consultant? Or do you have some other organizational role? The second question is, what is your role? Are you a clinician? Are you part of management? Are you involved in quality improvement? Are you involved in IT?
All right, Dr. Haughom, I've got the first poll up for right now. We've got a bunch of folks are voting in on this one. I'm going to leave the first poll open for just another few seconds, and then I'll get that second poll question up in just a moment.
Okay, thank you, Tyler. As I look at the results, it looks like integrated delivery systems and physician groups are roughly about 42 to 44%. 27% consultants, and 30% other. It's kind of what we had for the first webinar last October.
All right, let me go ahead and put that second poll up.
And in terms of how folks are involved, in terms of what their role is, now it looks like it's settling out at around 8% clinicians, 41 or 2% management, 15% quality improvement, 23% IT, and 16% other. Again, this is fairly reflective of the poll we took in October. I guess my only comment would be it would be nice if we could get more clinicians involved in this, because as I'll point out in this presentation, they ultimately are the answer to the challenges we face in healthcare. Okay, thank you for your response. To start, let's review some pertinent history. For the first 6,000 years of recorded human history, if you were ill or injured and saw a physician, your chances of survival actually went down. When hospitals appeared on the scene in the early 18th century, they were where people went to die. Actually, hospitals were where the poor went to die. The wealthy could afford to hire a doctor to take care of them at home, and they generally died at home. I would call your attention to the picture on this slide. Chiseled on the stone is the Code of Hammurabi. The Code of Hammurabi is a well-preserved Babylonian code of ancient Iraq that dates back to about 1772 BC. It is one of the oldest deciphered writings of significant length in the world. As you can see in the lower right hand of the slide, Law 215 out of 280 laws had to do with healthcare. Pay for healthcare services at that time were pretty modest. 10 shekels for surgery, which in today's terms is about $2.60. And peer review was far tougher than it is today. If a surgeon made a mistake, their career was promptly cut short, since it's pretty hard to perform surgery without hands. While healthcare did not offer much benefit for the first 6,000 years of human history, things profoundly changed starting in about 1860. Between 1860 and about 1950, a handful of visionary clinical leaders profoundly changed the course of healthcare history. These leaders included Sir William Osler, William Halsted, Howard Kelly, Florence Nightingale, William Welch, Harvey Cushing, and a number of others. These were leaders not just in name, but in action. It is possible to credit the impact of these visionary leaders to a handful of important advances they instituted. During this period, new high standards for clinical education were created, including 4-year medical schools with 2 years of book study and 2 years of hospital ward experience. Strict requirements for professional licensing were established. Clinical practice began to be founded on scientific research. A new internal organization for hospitals was identified. New, more modern nurse practices were created. More modern hygiene techniques were implemented. And new public health policies and treatments were put into operation. These advances set the stage for some amazing progress. While we have significantly improved on the work of these amazing clinical leaders, the fact is that much of healthcare today still reflects the work that they did. Harvard medical professor Lawrence Henderson recognized this change in the trajectory of healthcare when he wrote of healthcare's Great Divide in 1912. Dr. Henderson wrote, "For the first time in human history, a random patient with a random disease consulting a doctor chosen at random stands a better than 50-50 chance of benefiting from the encounter." Since that time, we in the medical profession have arrived at a point where we routinely achieve miracles. Over the past 100 years, and for the first time in 6,000 years, healthcare actually mattered to patients. Over the past century, we've progressed to what is easily the best healthcare system the world has ever seen. This slide illustrates a few of many significant advances. From 1900 to 2010, average life expectancy at birth increased from only 49 years to almost 80 years. Since 1960, age-adjusted mortality from heart disease, the #1 cause of death, has decreased by 56%. Since 1950, age-adjusted mortality from stroke has decreased by 70%. I could provide countless other examples, but these few examples make the point. Humanity most definitely has benefited from the advances in healthcare over the past 100 years. The next slide helps make this point. It is illuminating to look at the change in life expectancy in the U.S. since 1900. The graph illustrated on this slide shows that a child born in 1900 had a life expectancy of just shy of 50 years. For a child born 110 years later, the life expectancy is almost 80 years, an increase of over 29 years. That's almost 3 decades longer. This is an amazing accomplishment, and frankly, something unseen in the prior 6,000 years of recorded human history, a period during which life expectancy remained relatively flat. A lot of this increase can be attributed to improvements in public health. That's why the first half of the 20th century, illustrated in this graph between 1900 and 1950, could be called the public health era. Because of public health advances, there was a gain of about 3.5 years in life expectancy with each passing decade. The increase was largely due to avoiding epidemics of infectious disease like cholera, typhus, and smallpox. Then, sometime between about 1950 and 1960, 2 things happened. First, we largely exhausted, though not completely, public health as a major source of increase in life expectancy in the United States. Secondly, for the first time, we began to document changes in life expectancy in the population as a whole from treatment provided by clinicians in hospitals and clinics. You'll notice that the curve on the graph flattens out a bit in the 1950s. Since then, there's been a gain of about 1.3 years of life expectancy per decade. Though less than the public health increase, against the sweep of human history, these gains driven by clinical care improvements are truly phenomenal. We stand on the foundation of 100 years of science that have massively improved our understanding of the human organism in health and disease, and given us thousands of ways to improve the well-being and life expectancy of patients. Only in the last 60 years have clinicians been able to show that clinical care can make a significant difference. Please note, this is in the lifetime of many people involved in healthcare today. During our professional careers, we have been able to do more than just predict whether a patient will live or die. We can actually change the outcome of illness and injury. We are the first generation of clinicians that can make that claim. That's something that I'm proud of and excited to be part of, and I expect many of you are as well. All this leads to an important point that I alluded to in my first presentation. Before we talk about why changes are inevitable and important in healthcare, it is important that we recognize what we've achieved. Despite all the challenges facing healthcare today, there is also a lot of good about our current healthcare delivery system. Most American hospitals and caregivers provide safe and effective care for the vast majority of patients the vast majority of the time. The vast majority of caregivers are well-trained and conscientious. In Western medicine's ability to save and extend life and to improve the ability of the quality of life for the ill and injured is nothing short of miraculous. We have come a long way, and we have a lot to be proud of. All of this history is important because it should influence how we think about the present and the future. No doubt we face many challenges in healthcare today. As healthcare increasingly contributes to the national debate, it's important that we debate in the context of the phenomenal progress that we've made in the past and the progress we're capable of making in the future. I am very confident that at least 95% of our peer physicians get up every day seeking to be the best they can be for the patients they serve. The same is true for nurses and all other care providers. They hold the professional expertise and a deep-seated passion for quality that can be tapped as we seek to address the challenges facing the healthcare industry and to transform our healthcare system. Therein lies the key to addressing the quality, safety, access, waste, and cost challenges facing the industry. We need to build off the phenomenal success of the past and tap the energy, expertise, and commitment of care providers across the nation and around the world. The day that that happens will be the day that the issues currently facing healthcare will be solved. In 1977, Aaron Wodolsky, an American political scientist known for his work on public policy, published a book entitled Doing Better and Feeling Worse, The Political Pathology of Health Policy. In the book, Wodolsky argued that the traditional belief that medical care equals health, what he dubbed the Great Equation, is simply not true. In fact, most of the bad things that happen to people are at present beyond the reach of medicine. Wodolsky effectively argued that more available medical care does not necessarily equal better health. The reality of this is illustrated in the next slide. One of the most cited statistics in public health is the imbalance of social investments in medical care compared with prevention activities. Approximately 95% of the trillions of dollars we spend as a nation on health goes to direct medical care services, while just 5% is allocated to population-wide approaches to health improvement. However, as this slide shows, some 40% of deaths are caused by behavior patterns that could be modified by preventative interventions. Genetics, social circumstances, and environmental exposure also contribute substantially to preventable illness. It appears, in fact, that a much smaller proportion of preventable mortality in the United States, perhaps 10 to 15%, could be avoided by better availability or higher quality of medical care. Thus, one could reasonably question a funding scheme that places so much emphasis on medical care and not enough on prevention. The fact that medical care historically has had limited impact on the health of populations has been known for many years. The data clearly indicates that we could achieve a much greater impact on total health by going after behaviors than by delivering care. To put this in perspective, a study published in the British Medical Journal a few years ago tracked approximately 35,000 people over about 20 years. The study looked at 4 behaviors related to health factors: tobacco use, alcohol use, diet, and exercise. And the study demonstrated that people who did well on all 4 compared to people who did poorly on all 4 accounted for a 14-year difference in life expectancy. Now compare this to all of healthcare delivery, which accounts for approximately 3.5 to 7 years of additional life expectancy. Doctors have little or no control over the 90% of factors that determine health, from individual health lifestyles such as smoking, exercise, and stress, to social conditions like income, eating habits, and physiologic inheritance, to physical environment, including air quality and water quality. In short, most of the bad things that happened to people at the dawn of the 21st century are at present beyond the reach of medicine. So how does this impact the healthcare policy debate? Everyone knows that doctors and nurses do help patients. We can mend broken bones, cure most infections, and successfully operate on diseased organs. Inoculations, infections, and organ repairs are very good reasons for having doctors, drugs, and hospitals available. More of the same, however, is likely to be counterproductive. Nobody needs unnecessary operations, and excessive use of drugs can create dependencies or adverse reactions resulting in patient harm. More money for clinical care alone cannot advance health. In the absence of medical knowledge gained through new research or of administrative and clinical knowledge to advance common practice into best practice, current medicine has gone about as far as it can. Clinical care is not likely to reduce substantially more if more money is applied, and one could argue that we should be advancing anyway, especially with the extensive expenditures that the U.S. already supplies to clinical care and the well-defined levels of wasted resources that could be applied in advancing clinical care. Spending on health is not necessarily bad. Would we rather spend our disposable income on a new car, a more powerful personal computer, or a TV instead? Some would, others wouldn't. As still illustrated in this graph, the real problem is that health spending as a percent of disposable income in the United States is growing much faster than disposable income itself is growing. Furthermore, this growth in health spending is impacting other important categories of spending, like education and socially beneficial programs. The argument is not that clinical care is bad, only that it's not good for everything. The marginal value of spending an additional dollar or an additional $1 billion on medical care is likely to be close to zero in terms of improving overall health and life expectancy. Policymakers believe, and probably correctly, that we are spending enough on healthcare delivery at this point in time. As this slide demonstrates, spending on healthcare in the United States has been growing precipitously for over 3 decades, and it neared $2.6 trillion in 2010. That's over 10 times the $256 billion that was spent in 1980. The rate of growth in recent years has slowed relative to the rate of growth in the late 1990s and early 2000s, but it is still expected to grow faster than national income over the foreseeable future. Healthcare spending is the biggest financial issue facing the nation. Addressing this growing burden will continue to be a major policy priority at both the national and state level and in both the public and private sector. In the private sector, excuse me, in the private sector, employer-based coverage for healthcare began following World War II. It has been a mainstay employee benefit for many decades. However, since 2002, employer-sponsored health coverage for family premiums have increased by an astounding 97%, placing an increasing cost burden on employers and on workers. An increasing number of U.S. businesses are less competitive globally because of ballooning healthcare costs. Furthermore, the United States has been in a recession for much of the past decade, resulting in higher unemployment and lower income for many Americans. U.S. economic woes have heightened the burden of healthcare costs for both individuals and business. These conditions have put even more attention on health spending and affordability. This raises the question whether health insurance will remain a benefit for everyone. Will health insurance remain a benefit? For many Americans, the answer is probably no. As a result of powerful financial trends, employers are steadily reducing health insurance coverage or eliminating it altogether. An example of this is IBM's recently announced plans to move about 110,000 retirees off its company-sponsored health plan and instead give them a single fixed payment to buy coverage on a health insurance exchange. This is a clear sign that even big, well-capitalized employers like IBM aren't likely to keep providing the once common health benefits as medical costs continue to rise. The move, which will affect all IBM retirees once they become eligible for Medicare, will relieve the technology company of the responsibility of managing retirement healthcare benefits. In announcing the decision, IBM said the growing cost of care makes its current plan simply unsustainable without huge premium increases. Since the IBM announcement, other large companies have announced similar plans for their retiree health benefits. IBM's shift is an indication that health insurance marketplaces, similar to the public exchanges proposed under the Affordable Care Act, will play a bigger role as companies move coverage down the path taken by many pensions, paying employees and retirees a fixed sum to manage their own care. If this is true of companies like IBM, it will be more true of small companies. In the future, increasing premiums and growing marketplace competitiveness will likely lead to more employers reducing or dropping coverage altogether. Data from a study published by the Kaiser Family Foundation last December demonstrated that less than 51% of employers now offer health insurance as a benefit. That is illustrative of a huge drop over the last few years. In the public sector, Medicare covers the elderly and people with disabilities, and Medicaid provides coverage to low-income families. These programs fell into place in the 1960s and beyond. Enrollment has grown in Medicare with the aging of the baby boomers and in Medicaid due to the recession. The Affordable Care Act is further swelling the ranks of Medicaid participants. This means that total government spending on healthcare has increased considerably. Escalating healthcare costs are straining federal and state budgets, hindering the nation's ability to pay for important initiatives needed to address other significant national issues. As this slide shows, the United States spends far more on healthcare as a percent of gross domestic product than any other country in the world. Escalating healthcare costs are hindering the nation's ability to pay for important initiatives needed to address other significant issues. In 2010, health spending in total accounted for 18% of gross domestic product, and it's been rising since. And as this graph shows, the total U.S. expenditures per capita in both the public and private sector is far greater than any other nation in the world. The United States is represented by the bar on the far left. The center red bar indicates the average of OECD countries who submitted data. Clearly, the U.S. is far outspending every nation in the world. A thoughtful analysis of this spending data brings a harsh reality to light. It is abundantly clear that change is inevitable. As a society, we are spending more on clinical care than we can afford, and we have promised more than we can deliver. In a 2006 study by David Walker, Comptroller of the United States, it was demonstrated that the unfunded liabilities in the U.S. totaled about $47 trillion. I reviewed this study with you during my first presentation. 2/3 of these unfunded liabilities, about $30 trillion, were as a result of Medicare. At the time of the study, the total net worth of the United States was roughly the same. We have promised an amount equal to our total net worth. Clearly, this is not financially prudent, nor is it sustainable. Something has to change. Some president and some Congress in the not too distant future will have to face these realities. These healthcare spending trends are simply unsustainable. And in the future, they will make change inevitable as private payers, public payers, and consumers demand the elimination of waste and better utilization of resources in delivering high quality and safe care using new, more efficient techniques and care delivery models. While there has been a return on this societal investment in medical care, it has not been as great as the country needs or as the country deserves. The solution to this national dilemma is twofold. First, we need to slow the rate of growth in spending on healthcare. And secondly, we have to spend what we devote to healthcare more efficiently, wisely, and effectively. Published studies indicate that the rate of waste in healthcare is somewhere between 30 and 50%. These causes of waste have to be eliminated. This waste represents hundreds of billions of dollars that could be devoted to making care better and accessible. Even if you look at just the lower estimate of 30%, it's about $800 billion that could be spent to improve care and make it more accessible to Americans. This is where aggressive data-driven process improvement enters the picture. The evidence is steadily growing that clinician-driven, data-driven quality improvement is the answer to our problems, just as it has been in other industries. Informed, inspired, and engaged clinicians can solve this problem. We will discuss this in great detail in Section 2 of my book and in the presentations related to Section 2. For now, suffice it to say that experience at leading delivery organizations has clearly shown that clinician-driven performance improvement can improve outcomes, reduce harm, increase patient satisfaction, drive out waste, and save large sums of money. Such value-based performance improvement efforts can assure that waste is eliminated and health expenditures are more efficiently and effectively used. In addition, new, more efficient, patient-centric, and ambulatory-based care delivery models need to be implemented. An example of this trend is the NCQA medical home. Technology and advanced data management will play a role in enabling these new care models. I will discuss this in more detail in Section 3 of the book and in my presentations related to that section. Several studies have shown that these technology-enabled models of care can reduce the annualized cost to manage some high-profile chronic diseases by up to 40%. Given that roughly 24 chronic diseases account for almost 75% of U.S. healthcare expenditures, these new models of care offer great potential to address healthcare inflation. They have also been shown to allow clinicians to manage more patients, which will help address a growing clinician shortage, especially for physicians and nurses. So what's the bottom line? The traditional healthcare approach, though it has greatly benefited humanity, is no longer working. It's no longer adequate. It's time for a new approach in healthcare. We need to take the best of what we created, carry it into the future, and then create new ideas and initiatives that will help us eliminate waste and improve care. In a world of increasingly constrained costs, we have to find a more efficient and effective way to spend the resources we allocate to care delivery, an approach that will improve quality and safety, eliminate waste, and reduce costs. Now, in addition to financial realities, there are a number of cultural realities that will influence decisions as well as we go into the future. Peter Drucker once suggested that culture eats strategy. There is definitely truth in this statement, and we ignore its wisdom at our own peril. In a 1965 speech, a physician said, "A man stricken with disease today is assaulted by the same fears and finds himself searching for the same helping hand as his ancestors did 5 or 10,000 years ago. He has been told about the clever tools of modern medicine, and somewhat vaguely he expects that by and by he will profit from them. But in his hour of trial, his desperate want is for someone who is personally committed to him, who has taken up his cause, and who is willing to go to the trouble for him." This quote illustrates a key point. Patients expect, want, and deserve a caring healthcare provider. In addition to caring or high touch, patients have other expectations as well. These include choice and a rapid response if they are ill or injured. In terms of choice, Americans have grown used to maximal choice. They are also accustomed to being insulated from the costs of care, although that's starting to change. While maximal choice may not continue for everyone, it will remain a powerful cultural expectation. The capitation movement in the 1990s largely foundered on this cultural reality. Patients want choice. It will be interesting to see if the Affordable Care Act faces similar challenges. Even if everyone no longer has maximal choice, when it comes to medical care, at a minimum, the American people will want and need to define the limits of choice. Patients will also expect a rapid response when they become ill or injured. This is an American cultural norm. This brings us to a discussion of the rule of rescue. In 1986, U.S. bioethicist Albert Johnson described the so-called rule of rescue. The rule of rescue refers to our need to rescue identifiable individuals facing avoidable death without giving much thought to the opportunity cost for doing so. Note the use of the key phrase, identifiable individuals. The rule of rescue describes the moral impulse to save identifiable lives in immediate danger, irregardless of the expense. Think of the extremes taken to rescue a small child that's fallen down a well, a woman pinned beneath the rubble of an earthquake, or a submarine crew trapped on the ocean floor. In these situations, no effort is deemed too great. In fact, American society frequently applies the same principle to animals. We will rescue the dog trapped on the ice, as one example. The rule of rescue has held particular significance in the United States, where the importance of the individual has long been a part of our cultural fabric. In the U.S., we tend to count ourselves as not truly human unless we pull out all the stops. Increasingly, however, healthcare ethicists and policymakers are asking whether this same moral instinct to rescue, regardless of cost, should be applied in the emergency room, the hospital, or the community clinic. The rule of rescue is reflected in how we spend on healthcare in the United States compared to European countries. In the face of major trauma or heart attack, we spare no expense, and our mortality rates reflect this reality. As this graph illustrates, mortality following a major trauma in the U.S. is half what it is in European countries. Likewise, mortality following a heart attack is also lower in the U.S., 2/3 of what it is in Europe. When it comes to premature infants, we also spare no expense, no matter how premature the infant is, and our mortality rates reflect it. Mortality for neonates in the United States is substantially less than in European countries. We also use advanced treatments more aggressively in the United States compared to European countries. The performance of renal dialysis in major European countries is substantially less than the US, as illustrated in this graph. Similarly, the performance of renal transplant in major European countries is also substantially less than in Europe. It is not that Europeans do not have patients that would benefit from dialysis and transplant. It is a matter of public policy in using renal dialysis and renal transplant in the treatment of advanced renal failure. The U.S. uses these interventions extensively. European countries much less so. Finally, let's compare mortality rates from cancer between the United States and major European countries as illustrated in this graph. Cancer is equally prevalent in Europe as it is in the United States, but we tend to treat it much more aggressively here, offering patients every opportunity to be cured or at least extend their lives. And our cancer mortality rates reflect this reality. However, there is a downside to this approach. Despite spending twice as much as the average Western European country for its health care, the United States lags on a number of health system performance indicators, including amenable mortality, that is, deaths that could have been avoided with timely and effective care. Examples of such conditions include diabetes and acute infections. As this graphic illustrates, in terms of total health, as measured by mortality amenable to timely and effective medical care, the U.S. does not do as well as European countries. The reason for this discrepancy is that the U.S. does not focus on primary care and prevention. Instead, we place a very heavy focus on rescue care. Many countries outperform the U.S. as a result of better public health, a greater focus on behaviors, and better primary care. However, the U.S. performs significantly better for those with severe illness or injury, that is in terms of rescue care, as a result of better access to technology, less explicit rationing, and easy access to subspecialists. Going forward, as pressure to control healthcare costs grows and the need to manage precious resources more prudently escalates, the broad application of the rule of rescue will be increasingly untenable. However, the cultural and moral instincts to apply the rule of rescue will remain. The desire to help those weakest among us will remain strong, especially when their small numbers allow us to see them as unique individuals. This will likely be a very difficult cultural norm for American society to manage as healthcare transformation unfolds. In summary, over the past century, there has been a remarkable progress, and we know medical care matters. However, medical care is only one determinant of health, and more money needs to be spent on other known determinants of health. Many policymakers feel very strongly that we don't devote enough resources to clinical care, and more dollars need to be spent on other determinants of health. At a minimum, this will put extreme pressure on those of us involved in healthcare delivery to reduce or eliminate waste in the delivery system. Powerful cultural norms like high touch, the desire for choice, and the rule of rescue will likely continue to play a significant role in patient decisions and influence how we allocate resources. Those needs are not going to go away. And at the same time, the pressure to achieve more value from the resources that we do dedicate to clinical care will increasingly grow in the years ahead. That is, healthcare providers and healthcare organizations will face intense pressure to use existing resources more wisely and to efficiently deliver more high quality, safe, and effective and accessible care within the limits of what the nation can afford. This is definitely possible. How it will be accomplished will be the focus of section 2 of my book and the presentations associated with section 2 of the book. And I invite you back to hear those and discuss them. This concludes today's presentation. This presentation is designed to be part of an educational series on healthcare transformation that generally follows the book I am writing on the same topic. We will be holding another presentation in early March that will cover the rest of the topics in section 1 of the book before moving on to the presentations covering section 2 of the book. Section 2 is the heart of the book. It is designed to help clinicians and healthcare organizations understand what they need to do in order to successfully ride the wave of transformation over the next few years. I invite you to continue participating in this educational series. I would also invite you to provide us feedback. I will happily make my email address available to you, and anyone listening is more than welcome to contact me with ideas, comments, or questions. My goal for this book is for it to be a highly valuable resource for anyone involved in healthcare. As a result, your feedback is incredibly important to me. The book will be available primarily in digital format, making it easy to enhance the book as new ideas emerge and as new directions become apparent. Please feel free to contact me with any suggestions you might have. This is exciting work, and I hope you will find this educational series very, very, very valuable. As a reminder, the first 2 chapters of my book are now available to anyone who is interested in reading them. Thank you for your time and attention. Before we move to the questions, I would like to pose 3 more poll questions. They're represented on this slide, so please vote now. First question, how difficult do you believe it will be for Americans to balance high touch, the need for choice, and the rural rescue with the need to control healthcare costs? Very difficult, difficult, or easy?
All right, I've got that first poll up, and I'll leave that open for just another few seconds before we move on to the next question.
Good. Well, the answers don't surprise me. Somewhere around 68 or 69% of you say it'll be very difficult, and 31% say it'll be difficult, and 1% say it'll be easy. I tend to agree with the roughly 99% of you that say that it's going to be difficult at best. Second question. Does your organization have an effective strategy to engage clinicians at data-driven improvement? Okay, it looks like we're kind of leveling out here. Well, I feel good about the response. About 53% of you answered the question in the affirmative, said yes. 31% said no, and 14% don't know. So it's, I'm pleased to actually see that 55% of the organizations that you represent are involved in this important work. And the final question, is your organization considering new care models like the NCQA Medical Home or other similar type remote patient management models? Well, it looks like we've leveled out. 64% say yes. That warms my heart. That's fabulous. That 2/3 of you are in organizations that are doing that. 11% no, and 25% are unsure. So about is better than I expected. I would expect about 50%, but still quite a few that don't do that. Okay. Get my slide to advance here. Just as a reminder, if any of you are attending HIMSS this month in Orlando, you will find the Health Catalyst booth at number 6076. There'll be some special presentations here of successful stories from of some of Health Catalyst's clients, as you can see on the slide. Also can see the hashtags for Twitter that are appropriate. Now I'll take time in the remaining 12 minutes to turn to questions.
And we'd like to remind everybody that you can pose your question by typing your question into the questions portion of your control panel. Looks like we've got quite a few questions, Dr. Haughom.
Yeah, we do. Somebody asked for the URL for the download the book. That'll come in an email, I presume, Tyler, correct?
Yes, we will make everyone who has registered and who's attended this webinar, we will provide the URL for that section 1 of the ebook along with the recorded webinar and the link to the presentation slides.
Okay, I'm scanning. There's lots of questions about getting a hold of the slides. Let's see. Somebody questions whether I'm providing a history lesson. The answer is yes, actually, because too often in the modern debate, the history is overlooked. And what we've accomplished over the last 100 years serves as a platform for going into the future. So I think, in fact, that history is very, very important.
Dr. Haughom, we've got a question here. It says, in the future, what will be the best practices considering benefit designs, engagement strategies, and consumer tools that drive optimal behaviors in personal health care engagement and decisions?
Well, that's a complicated question with lots of different nuances in the answer. Let's start with, I think that what's going to happen in the U.S. is we're going to see more and more emphasis being placed on having patients feel the impact of their clinical decisions and the healthcare that they request. That's going to make them more sensitive and price sensitive, which in turn will, I think, influence their desire to pay more attention to behaviors that will help them avoid those expenses. I think the U.S. Has to get on with developing some very interesting models that are less hospital-centric and more ambulatory and patient-centric, using technology to enable them. That will be a subject of a presentation later in this series, but it's very clear that those models will save substantially in terms of costs and put patients more in power of their health and their health decisions. It would be very empowering for patients. It doesn't mean that the hospitals will go away. Our aging population will assure that they won't. But we do need to shift the emphasis more to the ambulatory world. Somebody asked a question about my view on medicine and how it's transitioning from more art to more science. That's an interesting question. I hope we maintain a balance there. As I tried to point out in this presentation, science is going to continue to advance, and we will, 50 years from now, be forming even more miracles than we have over the last 100 years. And so that's very important. And the rest of the world, quite frankly, looks to the U.S. to continue to advance the science of clinical care. Having said that, is that one quote that I provide you, I think very capably illustrates, when people get ill or injured, they deeply appreciate caring and compassionate providers. And we must never forget that as we go forward. And that will be a key success for healthcare providers and healthcare organizations going forward.
Okay, Dr. Haughom, we've got enough time for 2 more questions. We do have a question. It says, do the 2 problems require different solutions? Slowing costs implies increased productivity, but being more effective implies improved outcomes. The 2 may be at opposite ends of the spectrum.
Well, I frequently hear people say they're at opposite ends of the spectrum, but I actually don't believe that that's true in the majority of cases. Now, you can always find instances where it's true, but I think in the majority of cases it's not true. And in order to confirm that, you just have to look at other industries, because as a matter of fact, in other industries where very similar approaches that I'll be discussing in section 2 have been implemented, the result has been huge increases in productivity and massively better, massive improvements in products and services. And I do not think it'll be any different in healthcare. And some of the leading organizations that have implemented these tools and techniques are in fact showing that's true. And in section 3 of the book, I'm going to have a chapter devoting itself to examples of that. Do you have another question, Tyler?
Yeah, I think for our last question, let's see, requesting a response to, we must move away from a statement. We must move away from a supply-driven healthcare system organized around what physicians do and toward a patient-centered system organized around what patients need. I think they're asking for your opinions in response to that.
Well, I couldn't agree more. Now, sometimes when I make a statement that's similar to that in an audience with clinicians, some people take affront at it. I don't think it's threatening at all to clinicians if patients become more empowered. In fact, I think it's quite the reverse. I think that patients, when they get ill or injured, know who they need to go to. You know, one of the things that I'm always amused by is the fact that insurance companies have striven for over a decade to get more involved in clinical care. Now, please understand, I understand the need for health insurance companies, and I know they have a role. Having said that, when people get ill or injured, what do? They turn to their local clinicians and they turn to their local hospital for care. And so the more we empower them, the more we inform them, the more we help them be involved in their decisions, the more it's going to put clinicians front and center and local hospitals front and center. And so what we have to do is prepare for them to come to us, and we have to be prepared to provide them the highest quality, safest, most efficient, and most effective care we can.